One of the issues with the various ILDs is that they can go undiagnosed for a period of time. The problem is that they present with symptoms that are common to other, much more common pulmonary maladies. Specifically, the main symptoms is usually progressive shortness of breath, typically or sometimes rather accompanied by cough, which tends to be a dry, hacking cough. Now, if you think about IPF in terms of the prevalence in the US, it's estimated that there are about 150 to perhaps 200,000 cases, and it's competing against much more common diseases like COPD, which also presents with shortness of breath, and there are approximately 14 or 15 million folks in the US with COPD. Then you have asthma, which is another 20, 25 million, chronic congestive heart failure, another 5 million, and so it's understandable why these patients can go misdiagnosed for a period of time before the appropriate diagnosis is made. Misdiagnosis happens in interstitial lung disease because patients can be misdiagnosed as COPD or asthma or another condition. A couple of papers from the older literature saying that patients will visit 2 or 3 doctors sometimes before the appropriate diagnosis is made. So it could take 3 months, it could take 1 year before the appropriate diagnosis is made. I believe this is changing somewhat today as increased awareness arises about the interstitial lung diseases. The problem with making a later diagnosis is that we do have effective therapies, antifibrotic therapies in particular. 2 of them are FDA approved, the one being nintedanib and the other one being pirfenidone. Both of these slow the rate of progression of disease. They do not reverse the disease. So the later the diagnosis, the more loss of lung function there is that you don't have the chance to recoup or restore. So the earlier the diagnosis is made, the better, because then the patient can start on treatment as soon as possible to delay or defer the progression of the disease.